So thank you all for having lunch with us. I hope you enjoyed today's program on optimizing heart recovery in cardiogenic shock and who's on your team. Today I'm welcome to have two esteemed speakers join at the podium. Dr. Gudemus is a cardiovascular anesthesiologist and critical care physician trained at Mass General Hospital. And during his tenure at Mass General, he served as the Associate Medical Director at the Heart Center ICU and the Medical Director of the ECMO program. After a decade at MGH, he joined the Cleveland Clinic of Florida as the Medical Director of the MCS program. And 3 years ago, he was recruited to Naples to establish the NCH Rooney Heart Institute, where he currently serves as the Chief of Cardiac Anesthesia, Section Head of the CVICU, and the Medical Director of the ECMO program. Alongside him is Dr. Carlos Alvear, who is a dual-trained cardiologist and critical care specialist who serves as the assistant professor at NYU Grossman School of Medicine and as the director of Cardiac Intensive Care Unit and ECMO program at Bellevue Hospital Medical Center. He received his medical degree from CES University in Columbia and completed his residency and chief resident year at St. Luke's Roosevelt. Dr. Alvear is a member of the Leadership Council of the ACC Critical Care Cardiology Section, where he also serves as the chair of the International Outreach Working Group and chair of Education and Webinars Working Group. He is also a member of 3CPR, Early Career Committee, and the Acute Care and Clinical Cardiology Committee of the American Heart Association. I lost my place. Dr. Alvear has published over 100 manuscripts, several book chapters, and has presented his work at many national and international meetings and is passionate about education. So thank you all for listening to our conversation today. Before we started, I just wanted to do a little poll. How many people in this room are pulmonary critical care trained? How many people are cardiac critical care trained? How many people are pharmacy? And how many people are APPs? Yay. Talk about an entire heart team group. And so this conversation is applicable to all of you, and I'm super excited to talk to you afterwards about some of the thoughts you may learn from this. So I'm going to turn it over to Dr. Alvear.
Thank you, Linda, for the kind introduction. Let me just move this here. As many critical care specialists, I don't like to stay in one side, so I'm going to be moving around, and so feel free to ask questions. And today, I hope that we can really get to talk to our colleague intensivists about how we tackle building a shock team and why this is important in your institution. These are my disclosures. But my most important disclosure is that I love teamwork, so I'm already biased about this. And second, that as Linda was mentioning, I'm that weirdly proud specimen of being a dual-trained critical care cardiologist. So I'm very happy to be here in front of colleagues who do ICU, not only cardiology. And I hope at the end of this talk, you're not going to be like this, but more like this side. So I'm going to divide my talk into 4 points. One is the why it's important to talk about cardiogenic shock teams. Who are the stakeholders that should be implemented or associated with this? The way we put together a shock team, the protocols and things that matter, and how to build this in your institution. So why? Cardiogenic shock mortality remains elevated. We have data from the 70s to date in this most recent database from the C3TN that we published, in which mortality for cardiogenic shock remains elevated to the order of 30 to 60%. And this is from cardiac intensive care units, level 1 in academic institutions. So when we look at the mortality in smaller hospitals that don't have the resources, it's even more compelling. Now, cardiogenic shock is a complex entity. It's not only about low cardiac output. You start in this spectrum where you start getting a spiral of hypoperfusion, inflammation, and the patient gets the disbalance between congestion, multi-organ system affection, and therefore it becomes more complicated. The reason why the specialists in the cardiac ICU or the general ICU taking care of these patients should understand these processes. It's not only about the heart. We should start having this cardiocentric approach and know that we have significant involvement in other organ systems, from delirium, respiratory failure being present, requiring mechanical ventilation in about 60 to 80% of the patients with cardiogenic shock, renal dysfunction, and other issues. Now, how do we approach this? So I always like to quote this picture that we took with Sean Van Diepen, who wrote the AHA statement of cardiogenic shock in 2017. We met him with Jake Jensen and Jason Katz after the pandemic for the first time together in the ACC. And he said, if you have 5 cardiologists, you're going to have 7 opinions because 2 of them are going to contradict themselves. And the higher the ego, probably the more controversy. But this was also very nicely demonstrated by Dr. Guido Tavazzi, colleague and collaborator from Italy, where he showed that when he surveyed about 340 people around the world, clinicians that take care of cardiogenic shock patients, we don't agree on how to approach this patient. Swan guns versus echo, balloon pump, Impella, ECMO, dobutamine, epi, norepi. We don't really have great data to support this. So therefore, it's important that you put your heads together in this very complex population where that is also very limited. But let's talk about cardiogenic shock classification. I like to approach this from the etiology point of view, severity, ventricular involvement, congestion profile, and hemodynamic profile. And then there are also some modifiers that are key when you are selecting therapies, particularly mechanical circulatory support. So etiology is not the same to have an acute MI shock versus a heart failure shock. Somebody with myocarditis or chronic heart failure acutely decompensated is going to behave very differently. Severity. We started to use the SKY stage classification that has been validated in multiple cohorts as a very important tool to help us understand how sick is our patient, the prognostic of this patient, and the way we want to escalate therapies. We also have looked at IVP shock 2 scores, vasopressor inotropic scores, SOFA scores, and they don't perform as well as the SKY staging. The cardiogenic working group taught us that there are also different congestion profiles. You can have non-congestive profile, cardiorenal, or cardiometabolic, with the cardiometabolic having the most severe organ system compromise with liver dysfunction, renal dysfunction, and therefore higher mortality. And in terms of hemodynamics, it also becomes more complex because not every patient in shock is hypotensive. And yes, sometimes that's something that we have to keep nailing to our colleagues in the emergency department where they say, oh, probably, the patient is not really in shock because there's no hypertension, but the blood pressure is 110/100. The pulse pressure is very narrow. And that was something that was demonstrated in the cardiogenic shock, in the shock trial. Now, the hemodynamic profile, as we always look at the patient who is hypoperfused and congested based on the landmark study by Jeremy Swan and William Gantz in the 1970s, we start thinking that things also differ because some of those patients, as I mentioned, are not going to have hypotension, but they're going to have low cardiac output and congestion, right? So we have to be mindful that they might deteriorate. Perhaps they're in the SKY B, and if we don't pay attention, that normal tension is going to become an issue. We also have the mixed shock or the vasodilatory cardiogenic shock. And in acute MI shock, which is where we have done most of the clinical trials, including the DANGER trials, about 5% of these patients, about 20% of these patients will develop a syndrome of vasodilation, which is associated with worse mortality. These are the two examples. This is data from the shock trial from Dr. Judy Hockman, where you can see that patients with normotensive shock will have low cardiac index, high wedge pressure. The ejection fraction is about the same as those patients with hypotensive shock, but the SVR is different. It's perhaps because the patient that is younger able to clamp down and vasoconstrict and maintain the mean systolic arterial pressure. And the mortality tends to be a little better in those patients. In the other side of the spectrum, as I just mentioned, about 18 to 20% of these patients will have a decrease on the SVR, and they don't always have sepsis. This is a spectrum of patients who will usually present late. They're very vasodilated because they have cytokine storm, and they will have significant higher mortality. Lastly, I like to think about ventricular involvement, which is something that we also learned from the cardiogenic working group. When you look at the patient selection, these patients, about half of them will have biventricular compromise. We used to think it's LV shock, but no, the septum provides about 40% of the mechanics of the right ventricle. So even approximate LAD can give you biventricular shock. And one key parameter that we used in the DANGER trial that I think was fantastic to look at the algorithm for selection of these patients was that they excluded patients with RV dysfunction, right? You really need to understand what type of ventricular compromise you're dealing with. And then, to make things more complicated, think about the rest. Does this patient have mechanical complications, a ventricular septal rupture, or an LV thrombus like this potato-like thing that we saw a couple of weeks ago in one of our patients? What are the bleeding risks? What is the access that we have in these particular patients? Is this a patient who is going to benefit from a femoral approach, or we have to think about an axillary approach that is going to be more permanent, more easy to mobilize, and so forth? So those things are all important. Now, shock teams do improve survival. We have single-center studies started by Innova Heart and Vascular Institute in 2019, published in JACC, demonstrating that survival for acute MI shock and heart failure shock improve after the implementation of shock teams. The University of Utah followed afterwards, University of Bordeaux, and more recently, the University de la Marche in France. Now we also have some multi-center studies, including the Cardiogenic Shock initiative from Detroit, and then the study that we published from C3TN, led by work done by Alex Papoulos, where we demonstrated that the institutions with shock teams have lower mortality for cardiogenic shock and optimization of mechanical circulatory support. In general, we found that we use less support, but when we use support in shock team institutions, it's usually more advanced support like Impella or ECMO. So why is it important? So you come back home and you talk to your colleagues and leadership and say, listen, let's take a look at what's happening in our institution. What is the mortality for cardiogenic shock? What is the length of stay? What about the resources that we're using? Get an idea of those metrics and start working with them, because those patients get sick and they're also draining a lot of the resources. Also us, as intensivists, as APPs, it's tiring, it's stressful in the middle of the night to try to make a decision on somebody who has multiple things happening. Call the shock team. You're going to feel much better supported. That has an impact as well in burnout. And define what is specific to your institution that needs to be addressed, the potential roadblocks, anticipate. In that way, you're going to be able to put it together. And I wanted to share this, that is data from our institution from 2022 to 2024, when we implemented a more robust shock team. We had it for several years, but now we have intensivists actively participating in this, particularly cardiac critical care specialists. Our survival for cardiogenic shock has significantly improved up to 80% compared to the rest of the C3TN overall. So who should be the members of the shock team? And I think we're going to talk about this in more details in the next version, but it's variable. You have to think about some major stakeholders: an intensivist, interventional cardiology, heart failure cardiology, plus minus surgery. Now, the intensivist can be critical care in general, anesthesia critical care, cardiac critical care, and depending upon who does the MCS escalation, interventional or surgery, they should be involved as well. This is one of the first papers published out of Duke from Dr. Sunil Rao, but these are the potential shock team members that you need to consider. It can be very dynamic. For example, we try to get palliative care involved in every shock team activation within 24 hours, not because we're going to give up, but because they really help us support the families and the teams and the decisions as well. And a key figure there is going to be is the shock coordinator, which we're going to hear about that in a second. Now, the shock team members will be dynamic. At the beginning, it might start with the interventional cardiologist. As you think about escalation, you're probably going to get cardiothoracic surgery. The pharmacists, as you go we have some pharmacists in the audience, but as you transition from the cath lab to the CCU, it's important to have somebody who's really going to tell you how to do the anticoagulation in the right way to prevent bleeding complications. And then one thing that is usually challenging in the middle of the night, but if you can get a hold of the primary cardiologist, primary care physician of this patient, it's very important because they can tell you what are the values and what discussions have taken place before the patient has cardiogenic shock. So what is in the shock protocol? Like, another day in the office. This is not me trying to play a victim here, but we get really, really confused what devices we use. And are we using it the right way? Because that's the problem. It's not about just implant the MCS and go home. The real work, the tough work is starting in the ICU when you're going to take care of these patients with intracardiac devices. You got to make sure that you're optimizing the management, that you're preventing complications. And then when the patient is ready, start weaning them off so they can come off this. That's why they have an impact. And for the first time in 25 years, they had a positive trial in cardiogenic shock. And the first cardiogenic shock study done with MCS was positive, was the danger trial, because, again, patient selection and care in the ICU is extremely, extremely important. The shock team in action, there are different protocols. I don't intend to go in detail because they're just real examples that have been published from different major institutions. I also want to share what we have in our institutions, where we have early hemodynamic assessment. We have pre-specified diagnostic criteria to escalate. What are the goals of management and the things that we really want to do? And in summary, just think about it includes multidisciplinary activation, early left heart cath and PCI for acute MI shock, early phenotyping of shock, severity, right ventricular, left ventricular. Are we also looking at the hemodynamics in the right way? I know sometimes we love this non-invasive cardiac output monitoring. Keep it simple, echo and SWAN, not one versus the other. All together, we're going to give you the best information possible. Protocolize, try to de-escalate as soon as possible, and monitor and prevent complications. It's a longitudinal process. Patient selection, you take them to the unit. Early mobility, this is a patient with a 5.5 Impella. get them out and moving so they can get to the next stage if it's going to be transplant, recovery, or LVAD. And benefit, and always balance the benefit and the risk. So how do we do this? This is a white paper that we published under the leadership of Raymond Yu. He really was a visionary. He works in a smaller hospital, but he said, I really want to learn from major institutions that put together shock teams and they were successful. And try to identify those key factors. Talk to your leadership, get the stakeholders, what are the barriers, your local resources, and very, very important, always review the metrics. Keep reviewing, feedback, debriefing, M&Ms, but M&Ms in a friendly fashion, right? You have to have psychological safety. And always celebrate your successes. You really have to show your nurses, your colleagues, the leaders, what's happening at your institution. This is our survival cohort of patients with cardiogenic shock. It was a major game changer to see our nurses who have seen these patients in the worst shape possible. Then they go to rehab, and they never seen them again, but coming back, one of these patients came back with her baby, and they couldn't believe it. It was really, really moving and important for them to see this. Now, when we make decisions, it's not always easy, particularly in the middle of the night when we have this patient crashing and burning. I think we all as intensivists have been there, right? And this is a really nice book that I recommend where Daniel Kahneman, who got the Nobel Prize for Economy, this is a paper about psychology, how we make decisions as human beings. We have two systems. The system one is a little bit more instantaneous, driven by instinct and prior learning. System two, you have deliberation there. But the important thing is that we all have biases. When we start talking about multidisciplinary teams, we might think about some therapies that we're familiar with, risk, benefits, but sometimes maybe no therapy is better. We need to make decisions quickly and escalate in a timely fashion. We want to have a serial assessment with close follow-up. And in this way, we're going to have more team engagement and appropriate resource utilization. So when we make the decisions, we have to make sure that we have good team dynamics, not like these two Brazilian politicians who went to the octagon to have a dispute resolved about forest. You want to think about that psychological safety. We're always going to have that super aggressive person who wants to put everybody on ECMO, and then we're going to have the more conservative person that everybody's palliative care. We'll have to balance those values and be able to listen to everybody. Have that ability to provide a dynamic, collaborative approach in a safe space, balancing the roles and responsibilities, try to be collegial and supportive. Use this as an opportunity to learn, to teach, to do research, to improve QI, because that's the way we get better in an institution that's taking care of these patients with cardiogenic shock. This is an editorial we wrote from a study from the Cardiogenic Working Group, at the level of the network. Okay, you might tell me, I work in a small hospital, I don't have ECMO, I don't have a balloon pump, what do I do? Well, create a network approach. Maybe you have a sole institution without any partners, but you might be able to find those referral centers that you're going to see, listen, I have a patient that I think is a great candidate for Impella, coming with a STEMI. You're not going to send that patient to a place that has a diagnostic cath lab. They have to go to a shock center. They can get a PCI, they can get an Impella. One of our shock centers, level 2, they get an Impella, but they come immediately to us because we take care of the Impella post-implantation. And then think about planning ahead. What are the local barriers, the institutional resources, the local champions and stakeholders, and potential solutions in that way? It can be very inspirational, guys, for you to really start thinking about this. You don't have to be the CEO of the hospital. You can be somebody who works day in, day out in the CICU and say, hey, I think we need to start a shock team in our institution. It really is a game changer for these patients with cardiogenic shock. So remember, shock is complex, phenotyping is complex. Multidisciplinary teams really, really improve outcomes. They can also improve resource utilization. I didn't show the slide, but the University of Utah had them publish a paper last year that they can be very cost-effective. Comprehensive shock protocols to have patient selection in an appropriate way with follow-up and prevention of complication. Acknowledge the biases that we have. Think about the way to integrate these shock teams. And in that way, the implementation of this is going to be much, much better. And if you have a small institution, if you have a large institution, partner around with the regional shock centers and EMS in order to be able to transfer this patient in a timely fashion. So at the end of the day, don't be so worried about this. If you don't have a shock team, you're always going to have friends to call. And remember, it's important to keep that spirit in a collaborative fashion, because the strength of each team member's individual strength is the strength of the shared team as well. And with this, I want to stop here and take any questions. Thank you.
Thank you so much, Dr. Alvear, and you did such a great job of introducing and talking about the importance of developing a cardiogenic shock team. I'm going to ask to hold off questions and continue on this conversation because we're creating a narrative between receiving patients from our community and creating the identification and the processes to move them through the institutions, and recognizing the importance of success being when we get them home to their families. How do we bridge those gaps? How do we ensure heart recovery for our patients and also ensure that we're getting timely care at the appropriate time in that patient's trajectory of illness? And for many of us that have been practicing a long time, we know that we have a lot more options than we ever had before, and we need to build that village and that community that can move those patients along. And it starts with developing cardiogenic shock teams and moves through the different parts of the hospital. And one of the emerging roles that is coming, and I'm proud to say, is this idea of having a temporary MCS coordinator. And these are people that are going to be able to help bridge the gap between identification in the emergency department, having them go through procedural areas, going to the units, and then beyond, ensuring that we do the best to maximize our patients' options for recovery. And with that, I have to turn it over to Dr. Kademas, who's going to spend his time talking about what happens in the ICU and how we do a better job of managing patients. So thank you.
Thank you, guys. Good afternoon. Pleasure to be here. I want to know, before we start, how many people work on a big academic institution versus community hospital? So how many of you guys are on academic institutions right now? Okay, probably half of those. And the other rest, I'm assuming, were in community hospitals. So for me, it's been a great experience to be able to transition from being at a Mass General and a Cleveland Clinic to go to a small community hospital in Naples to build a program. And we're going to be showing how we did it. The other one. Perfect. So this is a regular cardiovascular ICU, and this was in 2017. And one of the challenges when we try to implement the idea of shock and talking with heart failure cardiologists and talking with surgeons and intensivists, who should be driving the boat? Who should be taking care of these patients? We have to understand that these patients have, as Dr. Aviar said, so many medical problems. So we have to be, as an ICU group, as an ICU team and APP providers, really in the middle of this. We have to understand that these patients are not going to go anywhere. We'll continue to see more and more devices and more ways that we're going to be able to help these patients. And the most important thing is, where is the patient? You can barely see them over there. You have so many devices and so many tools that we have to find a way to work together with the different specialties to take care of them. Why? Because they have multi-organ failure. They are complex patients with multiple challenges. So when I think about the role of the intensivists and the APPs in the ICU, we need to be the ones looking into early recognition of shock. We have to figure out what's the best device for our patients. We have to be the coordinators for these multidisciplinary teams. It's impossible to do it without us. So we are experts on ventilation, we're experts on multi-organ failure, and in order to optimize these patients, ICU needs to play a bigger role. This is a different patient from just a few months ago, more prettier pumps, but at the end of the day, it's the same patient on cardiogenic shock. This is a open chest coming from the OR on an ECPELA configuration on dialysis. So we have to figure out a work together to cut on this spiral. We have to find a way as a group to reverse this cardiogenic shock. Sometimes we can see the patients in advance in the ICU, but sometimes, on the majority of the time, we take the patients either from the cath lab or from the OR. So we have to work together and figure out how. But before, I have a couple questions for you guys and a couple thoughts. So when we look into the cardiogenic shock survival, we are not there, and we need to be able to work together as a group to improve survival. And we have the most experienced and talented medical teams probably in the world. We have more resources than any other peers in the world. We have the latest technology at our disposal. We have the backing of powerful and knowledgeable leaders, and yet, despite all this, our outcomes are not where they should be. Can anyone here tell me what that is? What do we think that is? And the way I see it is because it's the absence of trust. We have to figure out a way to work with different specialties and to trust each other. And when we look into this, is cardiogenic shock pathways are complex. And in our training, we are trained differently. And I'm an anesthesiologist, so we have a different training than pulmonary critical care, than cardiology, than surgery. We have to learn to speak the same language. We can have the best physicians in their specialties. If we don't speak the same language, we're not gonna get there. And the basic language that we have to understand is that cardiogenic shock is a flow problem. It's not a blood pressure problem. And when I was in medical school, it was all about blood pressure. And even in residency, hey, what's your blood pressure? Your blood pressure is good? We're good. It's not the case. So we have to understand that, and we have to be able to speak the same language that the heart failure cardiologists are talking, or the cardiac surgeons are talking, and learn that we have different devices that we can get us there to improve survival. How are we going to do it? Creating protocols. This is a great paper from Jack from a few years ago showing that 82% of acute cardiogenic shock survival in 2018 if we have a protocol that focuses on identification and profiling, minimal amount of pressors and inotropes, and we have to go back to the basics. A patient on a little bit of levo and a little bit of dopamine, that's not normal. So we have to go back and say the patients have to be really in bad shape even to go and show up in the ED. Now they are in pressors in the ICU. That's not normal. So we have to figure out a way to improve flow. An important thing is that the more that we delay this, the mortality increase. So, and we continue to see data all over, coming from all over the world, showing, and these are the ESC guidelines from a few years ago, changing their recommendations on mechanical circulatory support from 2B to 2A, showing the benefit of devices, using the devices sooner than later. And how are we going to get there as a specialty? Even ICU physicians and APPs. We have to recognize and assess these patients differently. We need to speak the same language. And the language that we want to be talking to and focusing on is the SCAI stages of cardiogenic shock to sooner recognize the problem. It's very easy to see the patient that is on 3 pressors with a MAP of 50 and the lactate of 10. Those are the patients that, how can we avoid that? What happened with that patient that is a SCAI C or D yesterday or 2 days ago? The sooner we can recognize this issue, the better. And especially for the APPs. We rely heavily on MPs and PAs. And the sooner you're able to get comfortable with this idea and help us elevate and go back, hey, to your heart failure specialist, to your surgeon, or to intensivist, about based on the hemodynamics of this patient, we have to escalate. And we have ways to do it. We have ways based on the SCAI recommendations of physical exam, biochemical markers, and hemodynamics. So in 2025, we have enough data, validated data, to support how to recognize this problem sooner. The other important thing is, if we're going to be talking the same language, we have to learn the basics and that data. And it's important to use the CPO. The cardiac power output has been there for years. This is a paper from 2004. And CPO is so important that you're going to see it on the console of our Impella device. So this is validated data showing that CPO is the strongest hemodynamic parameter that we have from the shock trial to profile these patients sooner. The same thing happened with PAPI. So again, what I'm sharing that this is important, validated information that we have to recognize these patients better. We have to come up with a guru that PA catheters don't work, from a paper from 20 years ago on ARDS patients with a normal heart. Understand that we have solid data showing the benefit of pulmonary artery catheters in patients on cardiogenic shock. We need to go back to use them, get comfortable with them, because PA catheters improve survival in cardiogenic shock. And we, as an intensivist, and as we go back and we continue to train our nurses and our APPs, we have to look into the different shock algorithms, but understanding that the more medications we use, the worse is going to be the outcome of these patients. And when I was in training, that we had the dobutamine attendings and the milrinone attendings, and then at night everyone will stop by medication, say you're wasting your time, let's go on dobutamine, and the next day we'll flip, thinking that was going to be the end. We have data showing that the mortality doesn't change with those two, and we have enough data showing that the more medications you're using, the worse is going to be your outcome. Also, lactate. Lactate is a strong predictor. Every time you get a call from the ED, that the majority of the time we think that hypotension is sepsis, get a lactate, get a point of care ultrasound, go and train your APPs in basics of POCUS, because that's going to help us recognize the problem sooner. So again, we're going to be able to talk the same, we're going to be able to speak the same language, and we're able to see and attack the problem the same. That's how we're going to create our heart team. We have to sit down with CT surgery, with heart failure cardiology, with pulmonary critical care, with anesthesia critical care, with pharmacy, with APPs all together, and come up with a plan. How are we going to do it? We can create a shock team. We can call it ECMO shock, whatever we're going to call it in our institutions. Important to have an ICU team member, that it could be an ICU physician, it could be an APP. It's depending who is there more, and where every hospital works differently. Sometimes we have hospitals in communities that don't have intensivists at night, but you have an APP. Those APPs are going to be key to be able to early profile and recognize these patients sooner. We need to be able to lead real-time decisions in these shock patients. And we're going to be focusing on early communication to see if this patient is a candidate for a CP or a 5.5 or an RP or ECMO or ECPELA. And important is that we get together every day with the different specialties taking care of these patients. We set up a time. It could be at 8 a.m., could be at 2 p.m. But important is that we all together focus on getting the team connected. And it's important to focus on creating your own protocols. Sit down with your groups and figure out what's gonna work for you. In medicine, since we went into med school and residency, we really focus on randomized controlled trials. These are the gold standards for us. And the ones that have been in research before, you can probably remember how difficult it is to enroll these patients. This is not easy. And the fact that now we finally have a randomized controlled trial that can help us guide this. I cannot tell you for how many years I was going to put a patient on ECMO. We were going to activate the team for an Impella CP, and the interventional cardiologist said, well, why don't we wait? We just don't have enough data. Let's be more conservative. Now we have data. We have the first completed randomized controlled trial in acute cardiogenic shock showing benefit. it took them years to be able to do this. So, and it was, as we all know, because we were all, if we're here today, we're very familiar with this trial, but they took 360 patients from 2013 to 2023 in different institutions with the idea of trying to prove that using an axial device and improving flow was going to decrease the mortality of this patient. The inclusion criteria were STEMI for less than 36 hours, patients with lactate, patients with low EF. And they were able to recognize and show a 12.7 reduction in mortality with number of patients to treat of 8. This is phenomenal because we finally have the opportunity to say, this device is going to help this young patient, or probably not a young patient. I mean, last week we put a 94-year-old that came with a STEMI on a device. He was in a honeymoon. He married at 72. He wanted to live 10 years longer. That's a problem that we see in Naples. And if you don't believe me, my 2 pharmacists are here, and we deal with this a lot. And the interventional cardiologist that was on call, it was very conservative. Well, I don't know. We have all the indications for it. This is a good patient. Let's put it on. The patient was on support for 48 hours, and we removed the pump successfully. So these devices are going to help us, and we just need to get comfortable and familiar with it. This is the first randomized controlled trial in the history to achieve primary survival endpoint. Is the first randomized controlled trial in MCS demonstrating survival benefits. We couldn't demonstrate that with a balloon. That was not a demonstration even with ECMO. And so adopting this is going to help your patients. So as we continue with the role, and this is again the data between the 3 different shock trials showing that the one that so far with absolute reduction in mortality is the danger shock, which is important to go back and share that if your shop is continuing to use intra-aortic balloon pumps for cardiogenic shock, this is a good opportunity to go back and say, hey, listen, we have to sit down together and figure out what can we do to use the right device for our patients. So as we continue to learn more about what to do and how to get comfortable with these devices, it's imperative that we understand how to treat the pump. And these pumps are preload. Let's say that now we have the patient in the ICU, what are we going to do with them? These pumps are preload dependent. These pumps are afterload sensitive. And to me, even the most important one is the positioning of the pump. If the pump is too deep or too shallow, can create problems. So when we talk about evaluate the preload of these patients, what if there is inadequate preload? Well, meaning if the preload is not enough, you're going to have multiple suction alarms, and you're going to create hemolysis. And you know, when I moved from MGH to Cleveland Clinic, these devices, we used to call it the hemolyzers, right? Because they hemolyze a lot. People didn't understand how to use it. At the clinic in Florida, was a lot of challenges using the device. And going to the cath lab sooner as an intensivist, I used to go to the cath lab and get the device out of the auto mode sooner. Evaluate the position before leaving the cath lab, and getting comfortable positioning this device in the ICU dramatically decrease the hemolysis in our patients, to the point that now we do close to 100 devices a year, and we rarely see hemolysis. It's because with every suction event, our APPs are trained, and we are training in the ICU to be able to look into the position of the pumps. So preload is important. If we don't have inadequate preload, we have to always looking for bleeding. If maybe the patients are getting too much diuretics, or the right side is not working. When we look into the afterload, it's the same principle. These patients are these pumps are afterload sensitive. Either the blood pressure is too high, or the patient is in a lot of pain or is agitated, or is on VA ECMO and the ventricle is empty. So we have to look into these parameters important. And as I will mention with the positioning is the key. We need to make sure that the angulation of the device is appropriate. We need to make sure that the device is not too deep or too shallow. And the easiest way to do that is with point-of-care ultrasound and transthoracic at the bedside. And what you want is to look at the device on the mid-ventricular space. If you're using a CP, it's going to look different than you have if you're using a 5.5, because the CP has a pigtail. So all those things are important for us to recognize. If you're using a CP, you want to make sure that it's approximately 3.5 centimeters from the aortic valve annulus to the mid ventricle. We have to be able to learn that how to see the end of the inlet and not get confused with the pigtail. And those are things that your the Abiomed clinicals are comfortable. We can provide a lot of education on this. And this is the key element to avoid hemolysis. So these are actually safety and easy mechanisms that we have to make sure that we provide the environment needed for these devices. This PAP, as simple as that, preload, afterload, and position, are really going to reduce the challenge of suction and adverse events. As a general consideration, we can definitely extubate these patients safely. We can sit them up all the way to 30 degrees. Use a knee immobilizer, because these patients are gonna be moving, and it's important to have them. You can perform dressing changes per protocol. Always access on rounds your access site for bleeding. Make sure that the device, someone has a hand on the device when you're moving the patient in and out. Monitor distal pulses. Find what's the best protocol to for managing anticoagulation. It could be ACT, could be PTT, could be anti-10A. We use 45 to 60 the first 24 hours, and then 60 to 80. We transitioned to Bible years ago, and knock on wood, it's been phenomenal, the experience. And now my head of pharmacy wants to do anti-10A, and we're going to be looking into that too. So we continue to look into the best ways to avoid hemolysis and avoid bleeding and clotting of these devices. As an intensivist, either APPs or physicians, early recognition and escalation. We have to learn how to escalate. We have to learn how to be vocal about these patients. If our hospital is not comfortable, find the hospital close to you to go for a 5.5, to go for an RP. Let's leave the ego, like Dr. Bill O'Neill always says, leave the ego outside of the room, put the patients first. If we think that we can offer more to these patients, if we can do it in our shop, fantastic. If we can go from a balloon to a CP, or from a CP to a 5.5, great. If not, let's get together and find the hospitals around us to help us escalate. Why? Because if we have a low cardiac power output and high lactate, that mortality goes through the roof. So allowing us to understand the importance of CPO and the importance of lactate are going to help with the morbidity and mortality of your patients. Sorry, I'm going backwards. So let's start with a case. We had not too long ago a 69-year-old male in the ER admitted with shortness of breath and chest pain. Blood pressure is 96/52, heart rate is 123, lactate is 5, creatinine is 1.7, troponins are 3,000. He's on a little bit of oxygen, he's an NSTEMI. We get an echo showing an EF of 25%, 2 plus MR, 2 plus TR with a dilated left atrium. The past medical history that every patient has, diabetes, high blood pressure, dyslipidemia, the normal, right? They do a cath, On the cath, the patient get a little more hypotensive, the EF is lower, and they put the impel up. Few hours later, patient continues to struggle. Liver fat is 8, lactate 3.2, CPO is 6, urine output is 20, heart rate is 102. And I got a call because my intensivist, this is in the middle of the night, and my intensivist called cardiology and surgery because he was concerned, and the surgeon said, "Oh no, I mean we can wait. Why don't you add dobutamine?" We got the patient, we got the surgeons on the phone, said there's no need for dobutamine, there is no time. We have to take the patient to the operating room right now for a 5-5. So the importance of having the team, this was a locum physician that we had covering the weekend, it's in the middle of the night. Those are the challenge. So as an ICU, we have to have a champion in shock. Someone that you guys can rely on, they can be the ambassador, if you may, with the other specialties to say, hey, listen, the dobutamine is not going to do anything. It's just going to delay the care. We need to take this patient to the operating room. And that's what we did. So we took the patient to the operating room to escalate to a 5-5. We can place the 5-5 when we have the CP there. It's actually easier. And then important to recognize the positioning on echo for these particular patients. This patient did very well, and we took the pump a week after. Another case, also on a weekend, 67-year-old hypertrophic cardiomyopathy, comes with acute MI, cardiogenic shock, goes to the cath lab, gets a CP in, LV function after 12 hours is bad with low cardiac output, high lactate. So Saturday around 5 p.m., the team goes, put a 5-5, and it was a long case. Patient was bleeding. Comes to the ICU, and a few hours after developing RV failure, RV dilation, multiple pressors, and now the lactate is 6. And a lot of people would have gone and put the patient on ECMO, and that's what the surgeon wanted to do. But we decided to go ahead and put an RP flex. If we don't have to jump into ECMO if the lungs are working okay. We have the ability, and this is what I love this device for ICU physician, because we can help. Actually, I'm placing the 90% of the RP flex. Me and my partner, both cardiovascular intensivists, and there are other institutions that ICU physicians are doing it. So I encourage the ICU physicians in the room to look into this, meaning we're very comfortable putting PA catheter. This is a PA catheter on steroids, a little bit of dilation, and it's going to be going very easy, I promise you. But it would allow you to avoid the ECMO. So we went to the operating room because the surgeon wasn't sure, but they trust us, and we put the device. And one of the things that we have to have with this device is that we have to play around, similar to what we used to do with the Vivat CentriMax, a little bit of fluids coming down on the support. As you can see, the left ventricle was suctioning and was small. So we were able to play around with the flows in the operating room, and then we left the operating room with the midline septum, both pumps working nicely. This patient was with us for 2.5 weeks. I tried to, and again, I work in a community hospital. We don't have transplant capabilities, and we have to learn when is the right time to send this patient. This patient was extubated within 24 hours. He was off pressors and inotropes, walking around, and after wake 2 with our heart failure team, we decided to send the patient for a heart transplant, and he was transplanted within 2 weeks, and he did pretty good. And again, the ability that we have, and the big academic institutions have an army of people. You have resources, you have residents and fellows and 3 intensivists at night within different ICUs. Meaning we had, when I started, 1 intensivist covering 2 hospitals. We heavily rely on the APPs, and you guys can really make a difference on these patients. So creating a team approach is the key. We have to do it together. And it has to be a combination of ECMO specialists, heart failure, ICU, IC, surgery, pharmacy, nursing. We cannot do it alone. And we have data. We present this paper in 2018 and JACC showing that multidisciplinary teams improve shock mortality and morbidity, timing of the escalation, reduce multi-organ failure, and we continue to see multiple protocols and multiple papers, as Dr. Aviar mentioned, in the ability to improve outcomes. We don't know who's the right intensivist to take care of these patients, and I don't think that should be the focus. If anesthesia is better than surgery or cardiology is better than pulmonary, it should not be the focus, in my opinion. The focus is how can we train our teams to take care of these patients? How can we learn to speak the same language? How can we advance, like the modernization of advanced life support? What can we offer to these critically ill patients to be able to improve outcomes? So I want to share with you our numbers at NCH when we started it. When we started it, I went to evaluate the program in 2020 and 2021. The amount of devices for acute cardiogenic shock was 9, and the survival rate was 25%, and we were not doing any 5.5s. So we got together. They said we have to work as a team. Everyone was a private practice mentality, working just on different areas. We sat down. We got the shock team involved, and we were able to improve the outcomes. How do we did it? Going back to the main question, and this is how I explain it to them. We have experienced physicians and talented clinicians. We have the technology with us. We have the support of administration saying we want to have better outcomes. How are we going to do it? Basically changing the mentality, trusting each other, working on conflict, having a team that can commit, accountability, and keeping an eye on the results. And this is, I didn't come up with this. This is from a great book of the 5 dysfunctions of a team. And these are the numbers now. We have close to 100 devices a year with a survival rate of 85%. Thank you very much.
Thank you so much, Dr. Cademus and Dr. Alvear, for all your information. Are there any questions in the audience? And if not, I have some myself.
Come on, at least a question.
Got to be something.
Uh-huh.
Okay.
Dr. Cademus, this is for you. I also work at a community hospital in Macon, Georgia. We're 6 months into our shock program, actually. You hit on a lot.
Congratulations.
Thank you. A lot of hard work. A few questions, if you don't mind. The first one is our cardiologists are private practice, and so incentivizing them to be part of a call team has been really difficult, and just their general involvement. So that was kind of my first question. How do you overcome that? Mm-hmm. Second one is just general hospital education, like from an ED floor level. Some of our intensivists have variable levels of comfort with PA lines and everything. And then thirdly is kind of hospital flow. So we wanted to be a referral system for devices, but we're not a transplant center. Mm-hmm. But bed availability is like a constant battle for us. Mm-hmm. And trying to have that discussion with administration of we should at least have a bed hold for referrals from smaller hospitals. And then secondly, kind of you alluded to that difficulty of discerning when to refer for transplant. how did you guys set up a system with the transplant center, and how do you have a protocol for deciding when to escalate them?
Great question. So let's tackle one by one. The first one was how do we get the cardiologists to work together on a private practice mentality? Is there, if we can show the community that our survival rate can go from 30% to 80%, they're gonna refer more patients. That's how we did it. And we said, I was able to share the numbers from my two previous institutions and say, listen, this is an investment for you. You guys don't need to be there all the time, because a difference to big academic institutions that we have heart failure, spending hours in the ICU on a salary, seeing 5 patients or 10 patients a day. In the community hospitals, these cardiologists need to go to clinic and see 40 patients a day, so they just don't have the time. But they were able to come up with a schedule and giving us an interventional cardiologist that was going to start rounding with us until we hire our own heart failure cardiologist, and now she was the one focusing on devices and creating the culture. So that was one, be able to say, if we can improve the you can use this in your advantage for more referrals. That was the first question. The second question was, where do we send the patients? So in Florida, we have multiple programs, but they're all far away from Naples. So for instance, Tampa is 2 hours away, Miami is 2 hours away, Fort Lauderdale is 2 hours away, Orlando, I left home at 5:30 and I got here at 11, so it's far. So, but we have to sit down with them. We had multiple calls, because at the end of the day, the families are the ones that are going to decide where do you want to send your loved one. So have the ability to connect with the intensivists there or the heart failure teams, recognizing that eventually we're going to be able to use their service. They all want these patients. So oftentimes, 1 or twice a year, we sit down with the different programs around the area to share protocols, to share practices. We just opened a cardiology fellowship program 2 years ago, and now our cardiology fellows go to these different hospitals for rotation. So that could be, and then what was the third question? About the beds. Yes, your bed. We don't hold a bed because that's a bed that a surgical patient will need. What we have is a plan to move some of the patients to a different locations. So my cardiovascular ICU has 10 beds, my neurovascular ICU has 17 beds, and our MICU has 25 beds. So we have the ability to really recognize at 6 a.m. and at 6 p.m. in the huddle with the intensivists, the APP, and the charge nurses to say, okay, we're full today. If we get an emergency, this patient A or B is going to be sent to a different unit. And that's how we were able to keep everyone happy.
Thank you.
And good luck. What you guys doing is important.
Hi there. My name is Eric Perez. I'm an intensivist. She mentions about training, like the whole team, there's different levels. How do you get there from a training perspective after you have an intensivist, after a fellowship? Is there any training course that you recommend, and especially also for APPs?
Do you want to?
Well, you should come to, there are several ongoing initiatives to train people, and of course you really need to make sure that they understand all these things that we mentioned in the protocol, from like being comfortable with swan guns. I think I love the fact that we really have to make a difference, and Dr. Cudemo say, swan guns, ARDS, whole different story. We have compelling data for swan guns. There is the PAX trial now recruiting for cardiogenic shocks, a prospective randomized clinical trial on swan guns. From that, patient identification, profiling, MCS management, and particularly in the ICU. I think we were just mentioning, the question was very good. I mean, and there are several programs in the country where I probably don't want interventional cardiologists managing the device in the unit. I want somebody who understands multi-system organ failure and everything from there. Now, there's some interventional cardiologists who are very well invested and they want to be there. That's great. But you really need to get all these different steps covered. There are national initiatives, that we're trying to get into. For example, the American College of Cardiology. We have, I'm one of the course founders. We have a symposium in NYU every October, the NYU Critical Care Cardiology Symposium, where we focus a lot on shock. Sky has a specific training opportunities. We have been discussing with Abiomed maybe starting to do some boot camps going to your institution about how you put together a shock team. What does it entail to train the APPs? We're developing a program as well with Linda where our APPs are getting trained on POCUS and positioning of the device as well, because you have to, it's not only the length, but for example, we make sure that everybody takes a look at the mitral regurgitation after you adjust. Are you affecting the flows? So you need the concepts and you need the hands-on. And there, we hope that, as people really understand the importance of this, the community starts looking for these programs that are already available out there, and you carry to that. And you need to, every year, do a little bit of a in-service on this, right? I think also with ECMO, because they're being established for 25 years already, they have this, and people do have regulatory processes when you go to an institution. But I think for shock is not only ECMO. And it really goes. My shock coordinator used to be called ECMO coordinator, and I say shock coordinator because it's a more global. You have to understand all these issues. And that person also in charge of okay, we need to retrain the team. You are due for, and you do it for your nurses, you do it for your APPs, anybody who comes to the unit. Even our trainees nowadays, my residents and fellows, and I love having them, but I don't rely on them to take care of the sickest patients. It's really the APPs who make a difference, who really have to have, we have a process of onboarding for 12 weeks, and then they have to take additional hands-on wet labs to be able to get there. So you individualize this, and happy to connect offline also to tell you some of the ideas that we do and the things that we share. But I think partnering with industry and looking at the device is not only the wrap and coming to show this is the device we have, but how we really put this together in a protocol. And that's the buy-in that you also need in private practice to tell people, well, you are going to start a program that is going to have a significant impact in survival, and making sure that it's carry over, because at the end of the day, that's what matters the most. If you see your patient surviving, people are also going to be happy. The revenue is going to improve as well in the way that you're properly using the devices, because you're going to have less complications, improve length of stay. So the administrators are also going to have to see this. It takes effort, but it's completely worth it.
Thank you again, and we're out of time, and I appreciate everybody's patience today, and I hope you take a lot of valuable nuggets. I encourage you to visit the booth at 901 to get some hands-on and to see what other resources are available to help improve and increase your care of patients requiring temporary support. Thank you, and have a great day.